Hello and welcome to the University of Calgary webinar about clinical depression, what you need to know. My name is Jennifer Alford and I will be your moderator today. And we will meet our scholar in just a minute, but first I want to give you a little information about what we're doing today and how the whole thing works. Now these webinars feature a series of University of Calgary scholars who bring us a summary of their research. We invite you to ask questions throughout the webinar, but in this case today we have so much material that we're covering. I'm not sure we're going to get a lot of time to answer questions that you send in, but I'm pretty sure that a lot of the questions that you have will be answered over the course of the webinar. You know, go ahead and ask the question. We'll get to a few, but we're not going to get to tons and tons because there's so much information. And speaking of information, there's also a resource list that you can find here. Just on the right of your screen under resource list, you'll find links to an article, to some PDFs about treatments that work, to an ebook. So please take a look at that. It's again on the right of your screen under resource list, or at the bottom of your screen, if you look for the icon that is a white paper on green, you'll find all kinds of resources there. Now we're on Twitter and we ask you to keep the conversation going on Twitter if you're there too with the hashtag #ExploreUCalgary. And finally, at the end of today's webinar, we're asking for your feedback. There's a quick one-question feedback survey that we're asking you to fill out to tell us what you think. You'll find that at the right of your screen, or again at the bottom of your screen with an icon that is a white clipboard on blue. Now, that's all the housekeeping. Time to meet our scholar. Keith Dobson is a professor of clinical psychology in the Faculty of Arts here at the University of Calgary, and he's the head of the Department of Psychology. Now, we're going to start off today with a little question to all of you guys out there about why you're interested in the topic of depression. So you'll see there are a number of different answers there. One, I have suffered, am suffering from depression. I have a family member or a friend who has suffered or is suffering from depression. I'm a mental health worker. I'm a mental health researcher. I'm a psychology student, or I'm just interested in the topic. So if you guys wouldn't mind just clicking which one relates to you. We like to ask these questions at the beginning just to give us a sense of who it is that is listening and who it is we're talking to, so that we, just so we know who our audience is. So we'll give you another minute here just to take a look at those answers, or those questions rather, and fill in your answers. Okay, let's see. Okay, there we go. Keith, do those answers surprise you at all?
Not really, Jennifer. It's good to see that there are a lot of people here who have a personal interest in the topic, because hopefully they'll get some good information that they can use either for themselves or a friend or family member.
Right. So now why don't we, thank you for that, everybody, answering that question. And now let's get right to it, because there's a lot of information to cover. Keith, what are the goals for today?
Okay, so first let me thank you for the invitation to be here today, and I'm pleased to do this webinar. And if there are questions, I will certainly try to address as many of them as we can in the time we have.
Thank you.
Yeah, thank you. So the goals for today are really threefold, large goals. One is to talk a little bit about the nature of depression, to talk about models of depression and how we've come to understand this, and some of our evolving understanding of depression, and then especially to focus on treatment, because I know that's what many people are interested in. So I'll just jump right in and start talking first about what is depression. And depression is a term that we use in our society quite loosely. So we often talk about feeling depressed today, or somebody suffering, their mood is not in a good shape. And so that's not what I'm talking about today. I'm not talking about just the mood, although depressed mood is certainly part of the phenomenon I'll be talking about. Depression can also be used as a symptom. So when we think about a symptom from a clinical perspective, what we're talking about is a sign or a symptom that contributes to a diagnosis. And the diagnosis is really something that comes out of what we call a syndrome. And a syndrome is a combination of various kinds of signs and symptoms that go together to form a diagnostic group. In our case, what I'm talking about is clinical depression, or what's technically called major depression. And I'll talk a little bit more about different patterns of major depression and clinical depression. But just for the audience's sake, when I talk about depression today, I'm not talking about a mood. I'm talking about this clinical syndrome.
You're not talking about having a bad day.
Not a bad day at all, no. More than that, for sure. And in fact, if you look at the next slide, these are the signs or symptoms of clinical depression that are in our current diagnostic framework. So if you went to a family physician or a psychologist or psychiatrist, this is what he or she would be looking at. And what they're looking at is a series of 9 possible signs or symptoms that need to be present for a minimum of 2 weeks in order to diagnose somebody with clinical depression. The first 2 of the symptoms on this list, the sad or irritable mood, so this is the depressed mood, is one of those signs. And the decrease in interest or pleasure is a second sign, and one of those has to be present. So we call these the cardinal symptoms. So to diagnose somebody, one of those must be present, but then 5 or more of the others. So what this means is that the presentation of clinical depression can actually look quite different from person to person. Somebody might just have 5 symptoms for 2 weeks, and they would meet the criteria. Somebody else might have all 9 symptoms for 2 years, and they would get the same diagnosis. But there's quite a bit of variability in terms of the way that people present and can be diagnosed with depression. But one of those first 2 signs or symptoms really does need to be present. The other thing that people will look at if they're diagnosing major depression or clinical depression is whether or not other factors are present. So for example, clinicians are not supposed to diagnose somebody as clinically depressed if they're taking significant amounts of alcohol or other drugs that can look like depression. And if we think about the signs of depression, many of them involve slowing down or shutting down of functioning. And so any kind of drugs that will stimulate that effect can potentially look like depression. And so what we'll try to do is take away that variance or take away that amount of understanding and then see what's left. So if somebody presents with significant alcohol problems, for example, and depression, what we would usually do is try to treat the alcohol problem first, and then having done that, see what's left in terms of the depressive signs or symptoms. So, and especially in the case of depression, we're looking for drugs that are central nervous system depressants. So drugs that, again, slow down functioning. These would be the ones that we're especially cautious about if they're present and the person is presenting with signs of depression, because they can simulate or mask or exaggerate the signs and symptoms of natural depression.
And some of those could be alcohol, but could some be pharmaceuticals too?
Oh, absolutely. Some can be prescription drugs, like, for example, anti-anxiety medications are generally slowing down the nervous system, so they can actually increase the signs of depression. Sleep medication, again, people that struggle with sleep, which is a sign of depression, are central nervous system depressants, so they help you to sleep well, but they can actually make it more difficult to get up in the morning and can actually exacerbate the signs of depression. Yeah. The other factor that we always look at is that whether there's a medical condition. So there are a few medical conditions that can either simulate the effects of depression or can make depression worse. And so again, most clinicians, if they are thinking about diagnosing depression, will get a referral to a family physician or possibly even to a specialist to make sure that one of these medical conditions is not present. So we want to make sure that that's not there as an exclusion.
For example?
Hypothyroidism is a common one that we would look at. So if the thyroid system is not functioning properly, it can look like depression. So there's one example. The last one I just wanted to mention briefly was about bereavement or grief. And this is actually a little bit controversial in the field, because in the previous version of our diagnostic system, if somebody had lost a loved one within 8 weeks, we are not supposed to diagnose depression. We're supposed to recognize that this is a grief response and let that sort of normally take its course. According to the new system, we actually don't use that as an exclusion anymore. So we are able now, within our current diagnostic system, to diagnose somebody with the signs of depression as being clinically depressed, even within a short period of time. And that's somewhat controversial. Some of the commonly associated features of depression, and there are many, but some of the more typical ones include performance problems, and again, depends on the place that the person is living or working. Social withdrawal or avoidance is a very typical associated feature of depression. Looking for changes in usual behavior, again, especially being shut down or quiet, becoming, for example, less talkative. That could be a sign of depression in some cases. Some people actually will medicate themselves if they start to experience the feelings of depression with drugs like alcohol or other substances. In fact, it's very interesting in Canada right now, because many of your listeners will know that marijuana is being legalized. And so it's going to be very interesting to see what the associations are with legalized marijuana and depression. And then anxiety. Again, approximately 50% of people who meet the criteria for major depression either currently are or in the past have met the criteria for one or more anxiety disorder. So anxiety is a very frequently what we would call comorbid or commonly associated disorder for depressive disorders as well. So again, from a treatment perspective, when we're trying to understand a person's depression, we would always be looking at these associated features and trying to develop a case-specific profile or understanding of the person. And it's not at all unusual, again, I'll just mention in passing, I guess, that when we treat people with depression, that as they come out of their depressive state, their anxiety may start to become dominant. So many people actually become anxious as they get treated for depression, and so sometimes the focus of care has to shift from the one condition to the other. This slide represents what we think about generally as the stages of depression. So what we think in the field is that it's an episodic condition for most people. So there's an onset, there's a period of time when the person is in an episode of depression. The first time they're in an episode, we talk about this as a major depressive episode. And for many people, this might be the only time they are depressed in their lives. But unfortunately, as we'll talk about a bit more in a second, many people will go on to have relapse or recurrence. So they'll have a second or third or fourth episode of depression. So what this slide represents is this idea that people will slip down for a period of time, but may have a relapse. And at the second episode, we would call it major depressive disorder.
And are these episodes 2 weeks, is that right?
Have to be each at least 2 weeks, but of course they can last longer.
Right.
Many different people have very different patterns. In fact, what we know on average is that the first episode tends to be the shortest and the most severe, and that if a person has relapse, often it tends to be a little bit longer, a little bit harder to get rid of, basically, and usually not quite as dramatic, but a little bit more chronic, if you want to think about it like that. And the third episode, again, often it's not quite as severe, but it's longer lasting. But it varies from person to person dramatically. The other thing I'll just mention here is that the way I've represented this is two ways. On the left side there you'll see scores ranging from 0 to 60. So those are scores on a very typical depression scale. And the truth is we have many different depression scales out there in the world that people can be assessed on. This is one that goes from 0 to 63. And on this particular scale, the cutoff is around 18 between people who are not depressed and depressed. So sometimes we use cutoff scores like that. We can also use the diagnostic system I talked about earlier as a way to think about depression. If listeners are interested, in fact, one resource which is available on the website quite easily is a measure called the Patient Health Questionnaire 9. And it has the 9 symptoms of depression, and you could do a self-assessment to determine your current level of functioning.
You could just Google that and find it.
You can Google it. It's a free access source. Yeah. Okay, so that's the Patient Health Questionnaire 9, or PHQ-9, as it's often referred to. How common is depression? This is an important question. So again, if you looked in Canadian society today, there are different estimates, and it partly depends on the methodology that's used. So I'll just say in general, if you do self-report of people's depression, often the estimates are higher. If you do more formal diagnostic interviews, the estimates are a little bit lower. So there's various studies out there that will give you different kinds of data. But approximately 2% of women today in Canada would meet the criteria for clinical depression or major depression, and about 1% of men. And over a year, about 5% of Canadians would meet the diagnostic criteria. And across the lifespan, something like 10% of women and 5% of men. So this is a very common disorder. And in fact, amongst all of the mental disorders, this is the single most common of all the diagnoses. If you take all of the anxiety disorders together, they're more frequent. But if you look for just a specific disorder, this is the single most common one that we find. So it's an important condition for sure. One of the things buried in that statistic is that women are at approximately twice the risk of men, and there are some reasons for that. And when I talk about some of the factors associated with the risk for depression, some of those will become maybe more clear.
So we'll talk about postpartum in a little few minutes.
Exactly,
okay.
Yeah, for example, that. One of the statistics, again, and this is somewhat controversial at this point in time, but we sometimes talk about a career of depression. When the person has a single episode, what is their chance of going on to have recurrent depression? And our best guesstimates now is that if a person has a single estimate of depression, once that's gone, they have about a 50% chance of having a second episode. If they have a second episode, their chances of having a recurrent episode after that, a third episode, go up to about 60%. It goes up to about 70% after that, and then it plateaus somewhere around 75, 80%. So the unfortunate truth is that if somebody has a single episode of depression, they are at increased risk for recurrent depression.
Not going to go away on its own.
Not always, but it can. The other thing is that first episodes of depression can really happen at any time in the life. There are two sort of higher risk times. One is late adolescence, early adulthood, where we tend to see a lot of first episodes of depression. And the other is sort of towards the end of the working career as people move into retirement. But it could happen at any time.
Well, speaking of working, are there some occupations that are more where you're more at risk for getting depression than others? Do you find is it more prevalent in some occupations than others?
Generally speaking, occupations with higher stress would be associated with increased rates of depression. When I talk about some of the risk factors, you'll see that if you're not as active, for example, you're probably at more increased risk. So generally speaking, I would say office careers, especially high risk or high stress office careers, would be associated with slightly higher rates. There is a recent study that looked at occupational categories, and if you do an analysis across the board, you don't tend to find much variation, but there's some. Yeah. So I don't know if the person that asked that question, if they're in a particularly high-stress occupation. The other thing we do know, though, is that some occupations are associated with higher risk of suicide. So, for example, physicians and dentists, and part of that, of course, is that they have access to medications that they could use. And so it's not necessarily that they're more suicidal, but they have the opportunity.
The means.
Yeah, the means, exactly. Yeah. Again, this is more technical, I think, perhaps than we need to be, but from a diagnostic perspective, again, we also think about subtypes of clinical depression. So in our diagnostic framework, we distinguish between major depressive episode and major depressive disorder, as I said earlier. We also have another subtype, which is called major depression with melancholia. Melancholia is where the person has a dominance of the physical signs or symptoms of depression, so things like sleep disturbance or appetite disturbance. And historically, there was a thought that that kind of depression was more likely a biologically induced depression and might more respond to biological treatment, like drug therapy for depression. The research doesn't support that, especially the treatment effect. It does look like even melancholic types of depression can be successfully treated with a variety of treatments that I'll talk about later. The other kind that we often hear about is something called dysthymia, or what is now called pervasive depressive disorder. And again, this is a more longer-term, chronic, lower-grade kind of form of depression. Many people, like I said earlier, if they have recurrent depression especially, the recurrent depressives aren't as severe, and so sometimes what we'll actually do is not diagnose major depression, but this kind of lower-grade, more persistent or pervasive kind of depressive episode. And then there's something called double depression, which is not actually technically a term in the diagnostic framework, but it's where people suffer from both dysthymia or pervasive depression, and then superimposed on top of that from time to time is a major depressive episode. So it's like a double whammy, if you want to think about it like that, which obviously is not a good situation. There also are some other variations. Seasonal affective disorder. So seasonal affective disorder is something that occurs when a person has major depression, but with a seasonal pattern to it. And in northern climates like Canada, it tends to be winter onset depression, but it doesn't have to be from a diagnostic framework. So as long as it's recurrent depression in the same time of year, and some people, for example, have summer depressions, this would be possibly a seasonal pattern. In the winter months, we associate this typically, of course, with changes in amount of sunshine that we get, vitamin D activation, for example. There are some thoughts that, in fact, it's associated with the biological effect or changes in the season. We also know that in our winter months, of course, we're less active. We also tend to stay inside more. We tend to eat more. We tend to put on weight. We tend to share communicable diseases. So our lifestyles in northern climates tend to also be kind of more risky, if you want to think about it like that.
One of our participants is wondering whether depression is more often genetic or environmental. You're just talking about seasonal affective disorder, which is environmental factors.
It can be.
Yes. Consensus on this?
Yeah, in fact, there is, and I'm going to, if I can, put that question off because I'm going to get to risk factors, and there absolutely is a genetic risk for depression. Yeah,
Stay tuned.
Stay tuned, yeah. We also know that some women suffer from postpartum depression. So this is a particular risk, which in part explains the increased risk for women relative to men. To diagnose postpartum depression, it's supposed to be within 2 weeks of childbirth, and it's probably associated with hormonal changes. And in fact, some women also, during the menstrual cycle, will experience changes in mood, which in some cases can meet the criteria for major depression. So that certainly is a risk factor as well. You had another question there?
I do. I would like to go through your list here of the different types of depression, but the question is that someone's asking is it possible or common to move from one type of depression to another?
Yes, absolutely. Again, unfortunately, people can have one pattern and then move from one to another. So, for example, they may start by having winter onset depression, and then over time the depression may become more chronic, and they may develop a dysthymia or a more pervasive depressive condition as well, for sure. Just a couple other quickly. Psychotic depression is a subtype that can be diagnosed. This is where the person actually may lose contact with reality. It's not the same as schizophrenia, which is related. People can have both major depression and schizophrenia at the same time. That can happen. But what we're talking about here is where people meet the criteria for major depression and their thinking is distorted, but as long as that thinking is consistent with the depression, so for example, if they feel that they're an evil person, they come to some delusional belief about being an evil person. As long as it's consistent with depression, we would call that the psychotic type of depression. So. And then finally is bipolar depression, or manic depression as it's often referred to, or bipolar disorder, many people would know about. Again, we tend to think of that as a somewhat different condition. It's where people cycle between low states of mood and activity and high states, so mania or hypomania. And that's quite a different condition. We think it actually probably has a different biological basis to it, and the treatments are somewhat different too. So I'm not going to focus much on bipolar depression today.
Okay, and you might be getting to this in a few minutes too. We have another question. Is this hereditary?
Okay, I will come to that.
Okay.
Good. Just very quickly, a couple things that depression is not. We don't think of it as an incurable illness, so even though it can become chronic, we do believe that with effective treatment, many people will get benefit, as I'll talk about. It's certainly not a sign of moral weakness or something that somebody deserves. There used to be some ideas that people who were weak or had dispositional problems sort of fell into this and they deserved it, but certainly we don't believe that.
Thank goodness for that.
Yes, and we certainly don't believe that it's necessarily caused by any one factor. So we don't tend to think about biological depressions or psychological depressions. Rather, the typical moderns are more complicated than that. And I'll come back to that in a second. Just wanted to say a few words about suicide. Again, if the listeners were watching the list of signs or symptoms, they would have noticed that one of those is the possibility of suicidal thinking or ideation or planning or actual suicidal behavior. And it is the case that there is an increased risk of suicide associated with depression. It's a paradox in some ways because it's actually formally one of the signs to diagnose depression, but it's actually not. Depression is not the disorder with the highest rate of suicide, interestingly. So again, it's somewhat controversial in the field, but we do know that the highest rates of depression are with psychotic disorders like schizophrenia, for example. Then bipolar depression even has higher rates of suicide than unipolar depression. Some of the risk factors include age, so teenagers, young adults, people past middle age are at a higher risk than the population at large, and gender. So women do, unfortunately, attempt suicide more. Men are more likely to complete suicide, partly because of the methods that they use. So men are more likely, when they get to that point, to use more lethal methods, and so their success rate is somewhat higher. And then race and ethnicity. We do know that there are some associations with American Indian Native individuals having highest rates based on Canadian data, but white men being the next highest group. And again, especially white males in the older age groups, so we're roughly 60, 65 and older. If you see somebody in that age group that's talking about or thinking about suicide, it should be taken seriously. Obviously, it should be taken seriously any time, but those groups in particular have relatively high rates. Some of the issues in suicide include the ways to think about suicidal ideation. So we know that one of the best predictors, and this is based on lots of years of research, for suicidality is hopelessness. So the way that many clinicians think about suicidality is that it emerges when a person is facing a chronic, unremitting problem that they've usually tried to solve and it just won't go away. And they develop a sense of hopelessness, and sometimes even helplessness about it. So it can emerge in the context of depression, especially chronic depression, if the person feels that it's never going to remit. But it can also emerge in the context of chronic medical conditions, terminal illness, following motor vehicle accidents. Again, there can be many different sort of risk factors, if you want to think about it like that, for suicidal thinking and hopelessness. We also know that in the context of depression, that perfectionism is an increased risk factor too. So people that have expectations that things should be a certain way, or that things have to go a certain way in their lives, and if those don't happen, and if they become hopeless about them ever occurring, that again can lead to increased risk for hopelessness and suicidality. Life events, stressful life events, generally increase the risk again, especially those that involve loss. So again, if a person loses a family member or a loved one, and there's no way to recover that relationship, that can certainly be associated with hopelessness. And so the irreplaceable loss, those can be precipitating factors. There also is some evidence of what we call suicide contagion, so that when somebody who's either in the media or somebody who just simply is known in your social circle commits suicide, others may come to that same idea that this is a way to cope with the problem, and so there is some evidence for suicide contagion as well. Some of this has been reported in the media, for example, in northern communities. Right. The other thing that we differentiate suicide from in the context of depression is also what we call parasuicide. Parasuicide is behavior that we think about where the person's goal is really not to end a hopeless situation, not to die, essentially, but rather to manage signs or symptoms. For example, we often see people who feel stressed, and they may have anxiety, for example, and one way that they find to relieve that tension is to cut themselves or to injure themselves. So we would refer to that kind of behavior as parasuicidal. It's not really the attempt to die. It's, it's self-injurious behavior, but it's not actually with the intent to end one's suffering.
Self-harm.
Self-harm, yeah, that's right. So differentiating why a person might be injuring themselves or taking pills or doing things that injure themselves is an important factor as well. And certainly from a management perspective, knowing that somebody doesn't intend to kill themselves will change the way that we might respond to that person's care. Suicide prevention, one of the things that we always deal with in psychology and psychiatry is trying to train clinicians to be aware of suicidal thinking, to be able to ask about it. One of the myths that's sometimes out there is that if you ask people about suicidality, you might increase the likelihood that they'll come to that idea, and we don't believe that.
You mean if you ask someone who might be suicidal how they're feeling about suicide?
That's right.
That
you might plant the idea or increase the likelihood that they're thinking about that. Generally, we don't believe that at all, exactly. What we tend to believe is that if a person is hopeless and is coming to the point of suicidal thinking, asking about it, in fact, is going to expose it. Often people feel supported and able to talk about these issues when they might not otherwise, and of course it can lead to effective problem solving. You have a question, I think?
Yes, someone's asking, are spouses of people who have committed suicide at a higher risk of suicide?
Yes, they are. They're both at a higher risk of depression and a higher risk of suicide. And again, part of that is this contagion idea. Part of it is the acceptability. And in fact, there's some evidence that suicide as a behavior, not that it runs in families, in the sense of a genetic risk, but that if a family member, parent, for example, has committed suicide, a child is more likely to come to that kind of thinking themselves. Yeah. So
what do we do if we think someone is at risk?
Mm-hmm. Great question. So what we want to do is we want to talk about it. We want to name it as a concern. Say ask the person if they're having these thoughts. We want to find out, if you can, what they're hopeless about, because almost always there's some issue. Sometimes you can help them to do problem solving about how to replace that relationship, if it's a lost relationship, for example, or whatever's happened to them. Getting them to appropriate services. So, for example, as it says on the slide here, identifying crisis centers or services. So in Canada, generally 911, of course, will access emergency medical services. So then you can get them to appropriate assessment and care. In Canada, we obviously want to protect people from themselves. So if they're actually thinking about ending their lives, getting them potentially into hospital. And in every province, people can be hospitalized even against their will if they're in acute risk for suicide, so that they can have a period of time to think about their lives and what they're doing. So we want to get them to care.
If somebody is in the throes of things, obviously you call 911, but if you're having a conversation with someone and you identify this hopelessness and helplessness, do you call 911 or a distress center?
Yeah, I wouldn't call 911 in the first instance because they're most likely to end up in the emergency room, and that may not be the best place, but it'd be more likely a distress center. Could be the family physician, of course. It could be, some families have sort of a wise uncle or a wise grandparent figure, so it could be somebody like that who might be able to come in and help the person solve their problems. It could be a spouse or a partner of the individual. Again, partly depends on the circumstances. Yeah. And again, the response has to be appropriate, of course, to the situation and to what the person is dealing with. The other thing that we know can help some people is what we call post-vention programs. So this would be for survivors of family members, again, who committed suicide, helping them to understand what happened and, again, to reduce what they often experience as self-blame or self-criticism for not taking actions that in hindsight they might have taken, but at the time they didn't necessarily know about. So post-vention programs can also be helpful. Some of the warning signs, and again, these are variable from person to person. I'm not going to go through them all because there's a long list here, and the people on the line can look at them separately. But basically, what we're looking for is a person typically who's kind of shy, withdrawn, maybe isolating themselves, and if we start to see changes in behavior, then especially if they start to withdraw more than they would otherwise if they were depressed, for example. If they start to, for example, do unusual things, they give back things that they've borrowed, or some people do what we sometimes call completion act. So, for example, getting their wills in order or making sure that their insurance programs are in place, those kinds of things. Those would be the kinds of signs and symptoms, again, that sometimes we look at after the fact. There's some thought that, when people get to the point of writing memos to themselves or, goodbye notes, that you're getting more serious again. So these would be things, if you know are happening, certainly would be all signs that you'd want to talk about and to get the person for care. Okay, so I'm not going to talk more about suicide, but if there are questions, people can certainly submit them. I'm going to shift gears a little bit, though, and talk about, again, risk factors for depression. And I said before that one of the things that we've come to believe generally is that depression isn't caused by a single condition or a single risk factor. The model that we tend to use in the field is a mouthful, and it's the biopsychosocial model, or biopsychosocial risk model. So this looks at the interplay among biological risk factors, psychological risk factors, and social risk factors, and how they vary, and can potentially lead to depression for different people. I'll talk about each separately. So some of the biological risk factors for depression, the other thing I guess I should say before I get into this is that all of the risk factors I'm going to talk about in the next couple of minutes have all been shown in research to be evidence-based. So there's a literature on all of these. So none of these is just sort of a conceptual idea. They're actually shown in data to be valid. So genetics. We do know that there's a genetic risk for depression. So for example, if you look at identical twins versus fraternal twins, there are increased rates of depression or concordance amongst identical twins. We know that when family studies have been done and you look at the amount of genetic similarity, if one person has depression and there's more genetic similarity, so for example, a mother and child, the rates of depression go up, for example. So there definitely is a genetic factor. We know that brain processes are also involved, and one of the main ones that have been looked at over the years is what's a process called neurotransmission. So the way that the nerve cells connect or communicate with each other. And again, if you think about the nature of depression, it generally involves a kind of a slowing down, avoidance, the decreased appetite, and so on, getting more tired, lethargy, and so on. So sort of a slowing down of the nervous system. So the major model that's been developed is that there's something that breaks down or stops or decreases the neurotransmission. And again, it's a much more complicated story than we ever thought in the first days, and I'll talk a bit more about some of the specifics of neurotransmission. But as a general idea, the brain processes. There also is research now, a lot of research going on, especially with modern scanning technology, trying to find out the locations for depression in the brain. And we know there's not a specific location, but there are actually a number of sites involved in the nervous system that are for depression. But there's a lot of work, again, doing imaging and scanning. Medical conditions, I already talked a little bit earlier about hypothyroidism, but again, increased influenza, hepatitis, mononucleosis can all actually simulate or actually in some cases stimulate a depressive episode. So these are medical risk factors. Hormonal changes, again, unfortunately, primarily affecting women, but the postpartum changes in hormonal variation, menstrual cycles, menopausal women, again, these are all increased risk factors for depression. Prescription drugs, again, I talked about this earlier and how we want to differentiate drug-related versus true or, clinical depression. And then in our society, especially alcohol use, this is one of our major central nervous system depressants, of course, that can look like depression. This slide actually represents in a bit more detail this idea of neurotransmission. And again, I'm not going to go into great detail just because it's, I think, too technical for our current purposes. But what it shows is that, in fact, the way the nerve cells communicate with each other is through chemicals called neurotransmitters. And in fact, in the nervous system, there are many neurotransmitters. So there's debates about which specific ones or which specific groups are implicated in depression. And there can be a number of ways that neurotransmission can be affected. So there could be either too little of the neurotransmitter created, there could be a breakdown in the communication between cells, it could be that the nerve cell that's receiving the communication doesn't appropriately receive it. And then there's another process called reuptake. So there's a normal process where some of the neurotransmitters get taken up by the cell that just released them. And if there's too much reuptake, in fact, that can break down neurotransmission. So there's a number of different processes that can go wrong. And again, there's a lot of research trying to figure out which are the most implicated. This slide represents some scans. Again, these are PET scans, so positron emission tomography, as it's called, scans of depressed individuals. And all I want to do here is demonstrate, if the people look at the top row of slides, this is somebody who has unipolar depression or major depression, but in a state when they're not depressed, so they're euthymic, so they're currently not depressed, versus the same individual when they are depressed. And you can see generally that there's just simply less activation. So again, it's consistent with this idea that the brain is slowing down, not that it's shutting down completely, obviously, but that its activity is reduced. And again, this is thought to be largely a representation, again, of neurotransmission, decreased neurotransmission. Psychological risk factors for depression also exist. So we know more increasingly, again, about early experiences. So the death or absence of a parent, especially before the age of 3, appears to influence people's ability to connect with other people, like to form their own attachments, and is a risk factor. Childhood neglect or abuse, or generally what we're now talking about as ACEs, the adverse childhood experiences, significantly increase the risk for later adult depression. And chronic illness or lengthy hospitalization, again, especially as a younger child, can again influence later development and potentially increase risk for depression. There's been a fair bit of research looking at parental depression, and it appears that it's primarily maternal depression that is a risk factor. So fathers who are depressed does increase the risk for children to also be depressed, but less than mothers. And again, we're thinking that it has to do with the process of attachment and connection to a parental figure, the primary caring figure in most families, still being the mother. So maternal depression. There also is, of course, a direct modeling effect too. If you have a depressed parent, he or she is in a sense teaching you how to be depressed. So there's that effect as well. We know that there are a whole host of negative thinking styles, again, that increase the risk for depression, and to some extent are signs or symptoms of depression. But even before a person is depressed, if they engage in rumination, for example, which is the tendency to have repeated negative thoughts, this increases the likelihood that at some point they will become depressed. And I'm not going to go through the other ones on that list, but basically these are all psychological factors that, again, have all got a database to support them as risk factors that precede the onset of depression and actually seem to get worse with repeated depression.
Can I just ask about
Sure.
personality styles quickly?
Sure. So, for example, perfectionism. I mentioned that
Right.
earlier. So perfectionists tend to be at increased risk for depression, for example. Social factors. Again, there are a whole host of social factors. Generally speaking, stress. Some stress, if you want a common denominator, but it can take different forms. But for example, if the person doesn't know how to negotiate their social world very well, so they don't learn good coping strategies, behavioral coping strategies, so they don't develop social skills or assertiveness, or if they tend to engage in avoidance and withdrawal as coping strategies, these do increase the risk for later depression, and to some extent, they're signs and symptoms of depression as well. stressful life events, poor social support. And again, poor social support can happen for a variety of reasons. It could be, for example, somebody who's got a good social support network and their best friend moves away, to another place. Suddenly their social support is taken away or reduced. Or, somebody who's got a very strong relationship with a partner and the partner dies, has an accident, and suddenly their major source of social support is gone. And that could be a stressful factor again. And then living with a depressed person. So in fact, there's good evidence that living with a person who's struggling with depression increases your own risk for depression as well. So again, all of these, like I say, are evidence-based. So what this leads us to then is that as a clinician, if we come to somebody and we recognize that they have major depression, what we need to do is stop for a moment and ask them about these various risk factors to identify what's going on in their life. And what we typically do then is develop a case conceptualization of that individual. Because not surprisingly, there's a general belief that if we can figure out the risk factors for that individual, we could probably target them and both help to treat the current depression and also decrease the risk of future depression. We also know that there are several resiliency factors. And again, to some extent, these are things that we work on in therapy when we're working with somebody who's depressed, but we also know from research, again, that they reduce the risk of future depression. So regular lifestyle habits like regular sleep is a protective factor. Exercise, again, in Canada, the recommendation generally is 3 times a week of aerobic exercise, some kind. So again, in therapy, if a person isn't exercising, we often will try to get these activities engaged. And again, important to note that it should be aerobic, so walking, swimming, cycling, something that gets your breathing up and gets your heart rate up. This is the kind of exercise that we're looking at. And then proper diet. Again, this can be important. There is some evidence about nutritional supplements as a treatment for depression. At this point, we don't see that as an evidence-based treatment, but it certainly doesn't hurt. If the person has dietary problems, supplements can help, of course. Increasing social support, again, especially if there's a decrease. And again, one of the general things we think about is trying to get people identified as early as possible and help them as quickly as possible, get them to effective care. And I'll talk a bit about access to care in a few minutes. So I'm going to switch gears again, looking at the clock. I think we're doing okay here. Switching gears to treatments, because again, I think people are probably quite interested in this. Generally speaking, just along with the same idea that no one cause for depression, again, we don't think that there's a single best treatment for depression at this point in time. Most of the treatments, and there are some exceptions I'll talk about, but most of them have roughly equal outcomes, based on the research that's been done. And combining treatments might improve outcomes, although there's a lot of trials, again, that suggest that they don't. So again, it varies depending on the study you look at. So what that leads us to is the idea that if a person gets treatment for depression and it doesn't work, what you should probably do is work with your healthcare professional to back up and try something else. And again, there's a whole range of antidepressant medications, for example. There are some evidence-based psychological therapies that I'll talk about. And so getting access to the service that you think is going to be the most helpful is important.
Lots of options for people.
There are many options. In fact, there almost are too many, I would argue, because it's bewildering to sometimes negotiate the treatment world. But but I'll come back to that. Yeah. And then the earlier the treatment is initiated, of course, the better the outcome. And that's been shown in research too, that the earlier the treatment, the less likely the person is going to develop a full episode of depression. That the episode is not going to be as long or as chronic. So it's not going to have the same kind of long-term consequences. And so we actually get better results in the short term, but also we reduce the risk of recurrent depression. So earlier treatment is important.
And does that go back all the way back to childhood kind of thing? Like
yeah.
If you can, okay.
Yeah, even if it's a child presenting, the earlier we can identify and help people, the better. And again, it's not just treating the depression, of course, it's also building those resiliency factors to reduce the likelihood of relapse. In fact, based on the research at this point in time, a general comment I would say is that it's very difficult to know who's going to have a first episode of depression. But once a person has their first episode of depression, it's a good bet that they're at risk for a second. So, again, a lot of our work in the field has been focused on preventing relapse. So this slide basically just says the same thing, that what we're looking for, again, are models that try to integrate different risk factors and try to optimize care to look for the best combinations. Again, I'll come back to that. So drug therapies. In Canada, the truth is that if you thought you were clinically depressed and you went to your family physician today and they identified that you met the criteria, you'd probably have a prescription this afternoon. So access to medications in Canada is actually pretty good. And there are a whole wide range of antidepressants, and I'll talk about some of them in a minute. For people that are listening and they're interested in the most current guideline, these are called the CANMAT guidelines and the Canadian Network for Mood and Anxiety Treatment. And the CANMAT guidelines list the most recent evidence-based treatments for depression and anxiety disorder, but depression in this case, including antidepressant medications. So people can go there as a resource afterwards. But in general, what we have are different classes or groups of antidepressant medications. And on this list, I haven't listed them all by any stretch of the imagination, but I just want to highlight, I guess, the three in the top group. The first one is called the monoamine oxidase inhibitors, or MAOIs. This is the first group of antidepressants that were generated back in the 1970s. They've been around for quite a while. Their success rate is about 2/3 for people that can work with them and can tolerate them. However, they have some quite significant dietary restrictions, and they often cause fairly significant side effects for people. So their tolerance is not so great, unfortunately. But they are effective antidepressants for many people. The second group of drugs is something called the tricyclic medications, because they have 3 carbon rings, so three cycles of carbon rings in their structure. These were developed in the 1980s and into the 1990s. They're still used as antidepressants. They still have about the same success, about a 2/3 success rate. They don't have the same amount of dietary restrictions as the monoamine oxidase inhibitors, but they do have side effects. Main side effects are what we call extrapyramidal effects: agitation, nervousness, tremulousness in some cases. So they have to, again, be given under care and have to be monitored. And then the most recent, which most people probably know about today, are the SSRIs, the selective serotonin reuptake inhibitors. And again, it's a mouthful, but basically what they're thought to do, their mechanism of action was thought to selectively target serotonin, which is one of the neurotransmitters, and to block reuptake. So to maintain transmission of serotonin based on blocking reuptake. And there are several medications in this group. They were developed in the 1990s and 2000s, and for many people, these are the dominant treatments that are still being given today. We actually don't know that they work by blocking reuptake of serotonin. There's some suspicion that, in fact, what they do is they increase the sensitivity of receptor sites and so allow neurotransmission that way. There's also some debate about whether or not they selectively target serotonin. So, in fact, there's some thought that they're not specific at all, or selective. So they may not be selective serotonin reuptake inhibitors, but they are antidepressants, and they have about the same success rate. They have fewer dietary restrictions for sure, and they have fewer side effects as well, so they're better tolerated. Then there are some newer generation medications, atypical antidepressants and so on, which again, people may be taking. Some of these are in the reuptake inhibitor group, but again, there's different mechanisms of action that are suspected for them.
And they can ask their doctors how that works, right?
If people are on these medications or think they want these medications, they should absolutely talk to their family physician or potentially be referred to a psychiatrist who can manage these medications. Yeah. Other drugs, again, that are out there, medical treatments, I'll just mention quickly. Lithium, some of you know about this. It's used for bipolar disorder, so I won't talk about it. Some people are given sedatives, primarily for sleep-related problems or tranquilizers. Antipsychotics are major tranquilizers, which slow down functioning, especially if a person has anxiety symptoms. And then one that's out there, it's been around for a long time, is something called electroconvulsive therapy, or sometimes called shock therapy, which does work. And of all the antidepressant treatments, this actually has the best results. It has about an 80% success rate. But its mechanisms of action are not well understood, and it does have some risks associated with it, including memory impairment and cognitive functioning. So it's usually not treated as a first-line therapy, but it can be beneficial. And there are others out there as well. So there's one called transmagnetic stimulation, which is being researched now. There's one called deep brain stimulation, which involves electrodes and so on. So again, if there's questions, I can talk about those, but those are less common. There are some effective psychotherapies, and the one that many people know about is something called Cognitive Behavioural Therapy, or CBT. And this certainly is the psychotherapy that has the most data associated with it. Again, it has about a 2/3 success rate, so it's similar to antidepressant medications. And again, one of the questions that may come up is about access. So at the footnote here on this line is that if you want a list of therapists in Canada that are credentialed to provide cognitive behavioral therapy, there's a Canadian Association of CBT, and their website is listed at the bottom. So
make note of that.
Yeah, so people can certainly go there, and you can actually search online to find a local therapist if you want. So that's one therapy. How does it work? Basically, it's a combination of factors. So there are therapist factors in terms of experience, knowledge, training, client factors in terms of their depression, so how they present with their depression, relationship factors. So we believe that part of any psychotherapy, in fact, is the relationship you build between the therapist and the client and how they relate to each other. But then there are intervention factors. So in CBT, not surprisingly, the therapy focuses on thinking patterns, so the cognitive patterns, and the behavioral patterns, especially things like avoidance. And there are a whole series of techniques that are used in the context of CBT that have been shown to be antidepressant through various research studies. There are some other therapies that also have data to support them, one called behavioral activation therapy. And this is one which really targets the behaviors associated with depression, so especially the avoidance pattern. And it doesn't pay as much attention to the thinking styles or thinking interactional patterns, but it's more stripped down in some ways if you think about it like that. Based on the current evidence, it's as effective as CBT. Now, again, there's limited research that's actually directly compared them, but there is good evidence that supports it. And in the same vein, I'll mention that there's some research looking at simple exercise. Aerobic exercise is a treatment for depression. And again, there's at least one well-done study that I'm aware of that directly compared exercise to CBT and had similar results. So getting increased activity is certainly important. Just like Nike says, right? Just do it, yeah. Probably not that simple, but that's important for sure, yeah. IPT is a short-term psychodynamic therapy. Again, it focuses, not surprisingly, on the interpersonal relationships of the individual and focuses on the way that you think about relationships, thinking about yourself in relation to others, and restoring relationships. So, and again, there's not as much data, again, to support it, but the data does suggest that it's an effective psychotherapy. There also is evidence for family therapy and generally what we would call supportive therapy or counseling, generic counseling for depression, not as much and certainly not as strong as the others. Family therapy would be mostly indicated, of course, if you're dealing with a child or adolescent or where the family needs to be implicated. But it sometimes also pops up in the context of, for example, elder person's depression, where the family, again, becomes more important. And so sometimes bringing in the family either as an intervention itself or in conjunction with drug therapy or in conjunction with another therapy can be sometimes important too. Lifestyle changes, again, focusing on those resiliency factors is also important. So again, physical self-care, improving social support, emotional self-care generally. So even things like, I shouldn't say even things, but things like yoga or programs of self-care, emotional self-care are important. And for some people, spiritual searching again. Especially we find for people that might be struggling with, what's my meaning in life or what's my place in life, and we have some existential kinds of questions. Sometimes spiritual searching can be very important. Very quickly, again, this is probably more information than people need, but one of the things I think that's important to think about is how effective are these the various treatments. So what I've done here is I've simply contrasted tricyclic medications versus SSRI medications versus cognitive behavioral therapy. If you look across the first row, it takes a hypothetical group of 100 patients starting care in any of those three conditions. And then how many people will finish therapy? So we have about a 30% dropout with tricyclics. So about 70 people will finish treatment, about 80 will finish the SSRI treatment, about 90 will finish cognitive therapy. So some people do drop out of psychological therapy, but not a huge amount. If you take the 2/3 success rates for all of the therapies, you get the numbers of people who would be successfully treated. And then if you look at an approximate 50% relapse rate a year later, what you can see is that, in fact, the treatment overall with the best longer-term results is the psychological therapy. And again, this has been more and more recognized, and a lot of the treatment guidelines now are recognizing that CBT in particular probably should be the first-line treatment. Not the one that we have the best access to in Canada, unfortunately, but it probably has the best short and longish term results.
That's good information.
Mm-hmm. Yeah, certainly if I had a family member who was clinically depressed, I would be looking for a CBT therapist. You know, but again, not necessarily alone. It might be in combination with pharmacotherapy. We have treatment guidelines that are emerging. And these guidelines on this slide are represented from NICE, as it's called, the NICE guidelines, which is from the United Kingdom. So again, these are not adopted yet in Canada, but this is the kind of care that I would argue our listeners should be looking for. So what we tend to think about is kind of a step or series of steps, so what we sometimes refer to as stepped care for treating depression. At the lowest level, these are people showing some signs or symptoms of depression, not necessarily meeting the diagnostic criteria. And in those cases, what we usually would do is what we call watchful waiting. So it's not that we tell the person to go away and don't come back, but rather we watch and we monitor their progress, make sure that they're doing helpful things to cope with their signs and symptoms. We give them information about depression. We help them to assess their own levels of depression, warn them about other signs that might emerge, and so on. So outpatient information. But basically, we're not treating them. You know, we're helping them to do self-assessment and monitoring, and we're doing that as well. The next level, we tend to focus on self-help care. So this could be written materials, it could be web-based materials, it could be, in some cases, minimal CBT care. So in the United Kingdom, they have people that they call low-intensity therapists, for example, that would be involved at this point, providing a few sessions of CBT kind of care, you know, based on best standards, again, based on the evidence. At the next level, and this would be where people actually do meet the diagnostic criteria for depression and didn't respond to the lower level of care, this is where you give a formal course of psychotherapy like CBT or medications, typically based on the patient's preference. Some people like to receive medication, so that's what they should get. And if they want a psychological therapy, that's what they should get. You could combine therapies at this level, but the evidence is that generally speaking, it doesn't help that much. And it's only for people that aren't responding there that then we start looking at combinations of CBT or psychological therapies and drug therapies. And this is also where we might be thinking about other therapies like electroconvulsive therapy or some of the more dramatic interventions. And this is where we might be starting to think about inpatient care. But again, truth is in Canada, very few people ever get inpatient care for depression. So in our context, that's not very typical at all. Does that make sense, that framework?
Yep.
Yeah, and again, that's step care. And of course, you can step up the level of care if the person needs more care, and you can step it down as well. Relapse and recurrence. Again, I'm not going to talk much about this, but it is important to note that increasingly we are worried about issues of relapse and recurrence because, like I said, many people will go on to have recurrent depression. So understanding the risk factors for relapse and recurrence is important. Again, I'm not going to go through them just in the interest of time here, but there are emerging risk studies that have been done. This slide represents some of the evidence-based research, again, for risk for relapse and recurrence. And what it suggests, of course, is that when we see these factors, we should be dealing with them in care. So it's not enough typically to just simply treat a person who's in a current episode of depression, but we should be anticipating these factors and trying to minimize them to the extent we can as well. There is evidence that CBT reduces relapse relative to medication. Again, I'm not going to talk about this because of time. I'm getting a sign here for those of you who can't see. But there is some evidence, again, that psychological therapies, effective psychological therapies, do reduce the risk of relapse. So there is some evidence that, in fact, they are affecting the risk factors, and having an impact there, like I said before. And there's another therapy I just wanted to mention some of the listeners, again, may know about called mindfulness-based cognitive therapy. And this is a specific kind of therapy that's been developed specifically for relapse prevention. And so it incorporates ideas about mindfulness or thinking about being depressed, sort of the attitudes that people have about negative experience, and tries to get people to be sensitive to their sensations and aware of things that are happening around them, to be mindful, and have awareness, but not to overreact to them. So to learn how to essentially treat these as momentary experiences and not to get depressed about being depressed.
Right.
This kind of idea. That's a bit of a simplification. But it's built, loosely speaking, on Buddhist principles, but there's good evidence that, in fact, it can reduce the risk of depression. And, in fact, this slide shows you the results of 2 trials that were done. Both of these compared mindfulness-based cognitive therapy, or MBCT, to treatment as usual, or TAU. And you can see that in the first study, treatment as usual had a relapse rate of about 66% versus about 37% in this trial for people that got mindfulness-based cognitive therapy. And the second study, without going into great detail, says that basically it looks like the treatment works best for people with more chronic depression, which is exciting. So again, especially for people that have had recurrent depression, MBCT may have a benefit for reducing the risk of depression, risk for future depression. Who can provide care? Well, again, I've already made reference to a whole host of different kinds of providers, but drug therapy can certainly be provided by a family physician or GP, also by a psychiatrist. In Canada, most people start with their family physician, and then if he or she runs into trouble, they might make a referral to a psychiatrist for more specialty care. Psychiatrists are more likely going to prescribe combinations of medication and higher doses of medication, but it varies depending on the person. Electroconvulsive therapy, or ECT, would almost be given by a psychiatrist. It's usually done on an outpatient basis, so the person goes into the hospital, gets their course of ECT, and then will go home again. But there has to be a specialist who does that. The psychological therapies, CBT, behavior therapy, interpersonal therapy, supportive therapy, can all be done by psychologists. And again, I would warn listeners that if you want to see a psychologist, and they say that they do one of these therapies, ask them for their credentials and training to make sure that they actually can provide the therapy, because some people will say that they know about a treatment, but they're not necessarily specialists. And some psychiatrists, many psychiatric programs will train people in psychotherapy, but they don't typically get as much training as a psychologist. And then there are also community workers as well, social workers and others that also get training in psychotherapy. Supportive therapy, again, is more generic and is provided by a range of healthcare providers. And social support can be given by anybody, any family member, anybody who cares, for sure. Living with depression. So again, I said earlier today that one of the risk factors for a person to become depressed is living with an individual who is depressed. Some of the things that you can do if you have a family member or even a friend who is depressed is to acknowledge their depression, to talk about it, to try not to stigmatize the person or blame them for their signs and symptoms if you can. If you're with a family member, try to maintain your own family relationships and your own behavioral patterns, so don't let it affect you too much. Try not to personalize the depression, which can be difficult, of course, especially if the depressed person is blaming you, which can happen in some cases. We would argue that you should try to involve the children if there are children, especially if they're old enough to understand, so as appropriate, or family members, again, as appropriate in discussion, and to help them to understand what's going on. Get the person to their physician or therapist and support them as much as you can by being caring and loving. And then finally, I think the last slide, there's things that you can do to prevent your own depression. So just a few sort of takeaways if you want. And these would be things like try to get regular sleep. This is certainly a preventive factor for reducing risk for depression. Generally speaking, we recommend that, it depends on the person. Again, people vary in their need for sleep, but approximately 7 to 8 hours a night, week in, week out. Don't go staying up till 3 in the morning on Saturday morning because you'll pay for it on Monday, that kind of thing. Exercising, like I said before, at least 3 times a week, eating healthy as you can, and again, developing your own social support network. And different people vary in terms of what they need. Some people have a broad social network. Some people have a narrow but very deep, social network. So maybe one or two really good friends. So it really depends on the individual, but developing their supports as they can. And I think that's the last slide.
That is an awful lot of great information. Thank you so much, Keith Dobson, for coming and giving us this primer on clinical depression. And thank you, everybody out there, for sending in your questions. As you know, we didn't get to many questions because we wanted to give Keith as much time as possible to cover as much ground as possible. But thank you so much for staying engaged, everyone. We appreciate that. Again, we have resources available to you here to the right of your screen under the resource list, or at the bottom there's an icon. Keith mentioned a number of different websites through the course of the presentation, which you can come back to if you didn't make note of them and make note of them the second time. So thank you again, everybody. And we have more webinars, one more webinar coming up in this flight about the microbiome and all your trillions of germs. So that's happening next week. Hopefully you'll come back and sign in for that one. And if you have, if you want to sign up for other webinars or download our ebooks or watch videos on other research, there's the website there where you can do that. And if you have ideas for other topics you would like us to cover, please email us and let us know. Thank you again for all of you today for joining us and for your patience in not getting to all your questions. I look forward to talking to you again next time. My name is Jennifer Alford.